Welcome, everybody. Thank you so much for joining us during the Johns Hopkins Alumni Weekend for this Hop Talk on real-time tracking and forecasting of COVID-19. My name is Mike Waters. I graduated from Johns Hopkins with a bachelor's degree in electrical and computer engineering. And currently, I'm serving as the co-chair of the Communication and Digital Engagement Committee on the Alumni Council. And I'm pleased to reintroduce here soon enough our Seattle area events, as I currently am in Seattle and looking forward to hosting chapter events for the alumni out here. Along with the reunion and homecoming office, we're pleased to bring this session to you today. In addition to introducing our speakers for today's talk, I'll also act as the moderator and will facilitate Q&A after the speakers present. So please feel free to submit your questions using the Q&A button down at the bottom of your screen anytime during the talk today, and we'll address those at the end. And now I'd like to introduce today's presenters. We have Ensheng Dong, Max Marshall, and Hongru Du. All three are doctoral candidates in the Department of Civil and Systems Engineering and have played an integral part in the creation and running of Johns Hopkins COVID-19 Dashboard. Under the leadership and guidance of Dr. Lauren Gardner, they have helped position Johns Hopkins as a leader in tracking and mitigating COVID-19. Ensheng Dong is the Lewis M. Brown Fellow and the 2020-2021 Dean's Leadership Fellow. His interests center on interdisciplinary research on network science, mobility modeling, machine learning, spatial analysis and visualization, and infectious disease. Prior to joining the Whiting School, Ensheng received his Bachelor of Science in Geographical Sciences from the Southwest University in China and his master's degrees in Geography and Statistics from the University of Idaho. Maximilian Max Marshall is the 2020-2021 recipient of the J.D. Samstag Fellowship in memory of Helen and Phil Samstag. His interests intersect on solving large-scale issues of technology, human behavior, and justice. Prior to joining Johns Hopkins, Max worked as an engineer for a biofuel startup company and received his bachelor's and master's degrees from Johns Hopkins. Hongru Du was the 2019-2020 recipient of the Richard D. Hickman Civil Engineering Fellowship. His research interests are stochastic modeling, simulation methods, and optimizations to solve real-world problems, such as improving current healthcare systems. Before joining Johns Hopkins, Hongru received his master's degree in industrial engineering from the University of Wisconsin-Madison and 2 bachelor's degrees from the University of Edinburgh and Tianjin University. I'm thrilled that Ensheng, Max, and Hongru are joining us today to share the details of their innovative and impactful work. Without further ado, please help me welcome Ensheng Dong, Max Marshall, and Hongru Du. Thank you.
Thanks, Mike. Let me start to share my screen. Just give me a second. Okay, the sound is shared. All right, hello everyone. This is Ensheng, and today I'm so happy to share our stories about tracking the global pandemic in real time. So a little bit about myself. So I came from China originally, and this is my hometown that is in red, and my city is pretty old. It's more than 2,000 years old. So when the city was built, Homer wrote the Iliad. It's about the same time. So I was taking my undergraduate in Chongqing, Taiwan. In 2012, I came to the US for my graduate study. And then I worked in different states in the US, like Idaho, Washington, California, Maine, and then I joined Johns Hopkins in 2019. And I'm so happy that my advisor is Dr. Lauren Gardner, and she gave me a lot of flexibility in exploring the different aspects of the public health. So back to January last year, when we were in a meeting in January 21st, and Dr. Gardner and we decided to create a dashboard to show the whole world how the coronavirus is spreading. So before diving into the dashboard, let's watch 2 video clips. So if you cannot hear the sound, please let me know. Thank you.
Each day, I receive a small card in my pocket I carry with me my schedule. It shows the number of Americans who have been infected by or died from COVID-19. Today we mark
Oops, some internet issue.
Okay. Truly grim, heartbreaking milestone. 500,071 dead. That's more Americans who've died in 1 year in this pandemic than in World War I, World War II, and the Vietnam War combined.
Okay, let's watch the second video.
Many policy decisions on this pandemic in Washington and locally are driven by the data, which we had no way to gather just a year ago. Here at CBS News, we rely on a tool that was developed by Johns Hopkins University that helps us understand exactly where we stand in this battle. Our lead national correspondent, that's David Begnaud, spoke to one of the people behind the site. David, good morning to you. The numbers are just unthinkable. The numbers matter here, and they keep climbing. Good morning.
Good morning, my friend. It's sobering to hear. If you go into Google and you type in Johns Hopkins coronavirus dashboard, this is what's going to come up. And if you look at it, this is all the cases in red. Look how many are on the eastern half of the country. This is the premier source for coronavirus data in the world. And since it launched last year, it has had more than 1 billion page views. Now, to give you a sense of its impact, when the president addressed the nation last night, he said that 500,071 people had lost their lives to COVID. That exact same number had been published on the dashboard yesterday afternoon, not the CDC's website.
Yes, our data is used everywhere, including President Biden. And here is an overview of our dashboard. You may see this dashboard a lot of times, but I will give you a brief introduction. Like the center part is the map, and each red dot representing the total number of cases in one location. Like in the US, the number represent each county. If you click on that, you can see the detailed number of cases and number of the death for that county. For some other countries like Canada, the UK, Russia, China, India, and Australia, those dots represent a province. And most other countries is only represented at the country level, especially for countries in Africa. And on the right and left part, you can see we have so many number listed with the country name. So here, like on the left, you can see the total number of the cases for the US, India, and all the other countries. If you switch to another tab, to admin 1, you can see the cases at the province or the state level. And admin 2, this one is specific for the US at the county level information. And here on the right side, you can see the total number of deaths for the global and the total number of recovered cases globally. And we have a lot of US specific information on this part, like the total number of the tests in the US. This is not the only one map we have. We also have the incidence rate. If you switch to another tab under this map, the yellow dot, the incidence rate means the number of the cases over 100,000 people in that location. And we also provide the case fatality ratio map. And this is the white dots. Case fatality ratio means the number of the death over the number of the cases for each location. And we also have the US specific information, which is testing rate. Other than that, we also provide many epidemiology curves like this one, the daily cases. You can switch to other type of the curves like the daily death and cumulative cases, cumulative death, and the log cases. And here down below the map, we have many information. So some people may ignore those information, but those are very important. Those include some definitions of our terms used in this dashboard, and some many other resources like where you can find the raw data for all the data we used in this dashboard, something like that. It's very useful. All right. I'm so happy to see our dashboard, and also the Johns Hopkins University Coronavirus Resource Center was on the list of Times Magazine 2020 Best Innovations. All the team members, we were so happy on that. 1 second, give me a second. So our dashboard was launched on January 22nd, and Dr. Garner announced announced that in her Twitter. That January 22nd is a very crucial time point because just one day ahead of that is the first case confirmed in the US. And just a couple of hours after we launched the dashboard, Wuhan, the epicenter, the whole city was locked down. So by far, we have many users. For example, this is the German government. They are using our dashboard. And also this is Italian government. They were also referring to our dashboard as their primary data sources, especially in the early stage of the pandemic. And this is the previous Vice President, Mike Pence, when he visited the Department of Human and Health. And this is our current President, Biden. He announced the number of the deaths in the US. So typically, if you turn on the TV and maybe, for example, here is the CNN, you will see our number is listed on their TV. Like here on the right part, you will see our number is on the upper right part, and the stocking market information is on the lower part. Sometimes you will see when the cases is going up, the stock marketing will going down. So that's an interesting coincidence. And also, our dashboard has been reported in many news and other organizations, like the Wall Street Journal. They praised our dashboard as a historical first. Like here, this is their comment. So by far, from the graph on the left, you can see how many usage we got. So you can see the peak days, that's maybe around the end of March last year, is about 4.5 billion per day. If you compare with the world population, I can probably say about at least half of the population in the world has had a click on our dashboard. And by far, we have been our dashboard has been requested by more than 205 billion. So this is a very tremendous number. So no wonder the Vice President of Johns Hopkins, he did a poll in Twitter, and the conclusion is the most impactful US academic institute in the COVID-19 crisis is Johns Hopkins University. And this one is also being supported by this Google trend. If you compare with the Google search in the past 5 years, you can see the red line represent the Harvard University, which means when people searching Harvard University, and the blue lines means people searching for Johns Hopkins University. And last year, there is a huge spike because a lot of people searching Johns Hopkins University, mainly because of our dashboard. All right, so our data from the beginning, we aim to share the data to the public. So we created this GitHub repo where we share the daily report and also many time series data. This is all our raw data. If you are a researcher or some students, if you're interested in our data, you can go to our dashboard GitHub and you'll find all those answers. And we also provided many other informations like if we back distributed any information, we will make a record. And if we change anything because of the official data has changed, we will also make that update in our GitHub repo. And the terms of use, we changed this one a lot because in the beginning, our data is only being used in the non-commercial organizations, but after a while, we found maybe it's a public data. Everyone should have a free access to our public data, public health data. So we decided to release the data to everyone, no matter your commercial or non-commercial organization or your personal or some institute, you can use our data for free of charge. And one good example is the Google Map. Right now, if you go to the Google Map app in your iPhone and then change the layer to COVID-19, the data is provided by us. And the data validation. So since the beginning, we are collecting data in real time, but at the same time, we also need to make sure our data is is correct. So we compare our data with other major data sources like WHO and New York Times. We compare their data line by line and to see it's all perfectly matched. And we also published this paper. And this paper describes how we maintain this whole dashboard and how we compare and validate our data. And this article has been cited for more than 4,000 times. The dashboard, when we created the dashboard, there is no other organization has been created such a tool before. So everything we need to explore by ourselves, like how we figure out the data issue, how we figure out the visualization, and how we figure out if different organizations that use different format for the publish the data, we need to standardize them. And we also met so many troubles and problems on the way we're collecting the data. So after a couple of months, we learned a lot from this data collection procedure, and we wrote an article also in the Lancet Infectious Disease to inform the public, what if there is another pandemic in the world? How should we collect the data? How should we unify the data sources? Those are very important issues. And also we raised the concern on the privacy and the public information. So how can we balance those two rings? So in the end, I would love to thank all my lovely team members. And you can see we have so many faces here. And this is a slide from last year's ESRI Award, because our team got the Making a Difference Award last summer. And I'm so proud to be one of them. And here is our sponsors. From Johns Hopkins Applied Physics Lab to ESRI and to Johns Hopkins Library. And we also got a lot of sponsorship from all these organizations. It is from their help, our dashboard to make the Johns Hopkins kind of famous. Johns Hopkins University is no longer, is not only famous for the medical school, but also famous for the coronavirus map. In the end, if you would love to explore more about the dashboard, you're welcome to visit our website at systems.jhu.edu. And if you have extra money, you can donate to us to buy us a cup of coffee by go to donate button. Thank you so much.
Okay, I will share my screen. Can everyone see my screen? Okay, so my name is Hongru. I am a second-year graduate student at Johns Hopkins University, also at the Center for System Science and Engineering. So I kind of want to take some time to briefly introduce our center, CSSE. So this is our center. Our center is led by Professor Lauren Gardner and Professor Kimia Gobadi, and we are under the Department of Civil and System Engineering. During the past year, 2020, when we are working our dashboard, some people ask me a question like, why you guys are doing this COVID tracking map? Why you guys are doing COVID research? You guys are not from public health, you are from civil engineering department. So I think the reason for that people are not very clear about what we are actually doing at CSSE. So I just want to talk about our research directions. From a very high point of view, we could say we are study system science, but system science is too broad. Actually, any science or engineering could more or less relate to system. So we are more specifically focusing on those three kind of directions, as you can see on this picture on the right. We are focused on the energy system, healthcare system, transportation system. We have an emphasis on the healthcare systems. Like our group, we study the infectious disease in public health. And for Professor Kimia Gobadi, for her group, they are trying to kind of help the hospital to better manage the patient flow over the pandemic. So we use a method like traditional mathematical optimization, like data science, the machine learning tools, and computational models. This is why all of us are coming from different backgrounds. Like Ensheng, he's from statistics and the geography. Like Max, he's from the civil department at Hopkins, and I am from industrial engineering. So diversity is very important in our group because people from different fields may have different point of views, and we kind of integrate all the point of view and to solve system problems. This is why we could modeling COVID and develop this dashboard. So our COVID related research is kind of a subsection under the public health. We are not only study the COVID, we also study other infectious disease like measles, like flu, dengue, Zika. But at this point of time, study COVID is much more urgent compared to other diseases. So we put more effort on COVID related researches. We develop a forecast model, simulation model that we could use to infer the future cases or future risk, that those models can be easily applied to other diseases. But right now we are focusing on the COVID. This is kind of very early stage of our COVID related research, just right after the kind of publish of our initial version of dashboard. We start to use those data to model the spread of COVID. So at that time, we kind of serve as the data collector, and also we are the data user that use the data that we collect ourselves and try to infer how those COVID will spread over the world. We use a SEIR model that built on the global mobility network, try to estimate the number of imported cases except the mainland China. So you can see this figure on the left is the number that we estimate how many imported cases will be in other region or country except China. So the top 10 country or region that we think at highest risk actually do have confirmed cases by the end of January last year. We also inferred the risk at city level across the country. And you can see at this map down below, it's for US. We see these cities like Los Angeles, Seattle, San Francisco, New York, Washington, DC, those are at higher risk of COVID importation. And we suggest that airport for the city kind of need to enhance their screening and security check. And in fact, those are the places that had been hit really bad during early stage of the pandemic. And the move to April, we get some real-time mobility data from some like mobile phone companies. And we start to use those real-time mobility data to study the transmission of COVID through the time. And first, we want to study the social distancing. Is lockdown really benefit kind of stop the COVID? As you can see from those two maps on the left-hand side, on the top one is for the mobility pattern in January, and the bottom one is the mobility pattern in April. The more the color close to red means the more people are moving around. The more the color close to yellow and green means more people are stay at home. And you can see there's the significant difference between how people are moving around in January and how people are moving in April. More people are stay at home. And we also find that there is a strong correlation between mobility pattern and the cases growth rate, which means that the more people are moving around, the higher the growth rate. When people stop moving around, we see there is a significant drop in cases growth rate. All of those results are based on the data up to April. And after April, there's some violation of this significant correlation. The reason for that is there are a lot of different policy deployed across the country, and people's behavior are kind of more complicated. There's a huge variance from place to place, so this strong correlation are no longer hold. As everyone knows that gathering behavior can be very critical in the spread of COVID. If a lot of people are gathering indoor without wearing a mask, it could be easily become a super spreading event. So we use those detailed mobility data to identify where all those events happen. And 2020, there are a lot of things happen at the same times. For example, for the Memorial Day weekend is at the end of May last year, and right after that, there's a BLM protest happen across the country. So these two gathering events kind of happened, overlap to each other. We use mobility data to identify those events. For example, like the figure on the left is for the Ocean City in Maryland. We see that there is a significant increase of visitor volume for those places that close to the sea. And the same is for the California. We identify exactly where and when this protest happened at census block level. Why we take so much effort on those mobility data? Because we think that mobility could be a proxy for humans' behavior. We think that people that are visiting a food service restaurant and have a dinner will be much more risky compared to you go to a national park and go hiking somewhere in the mountain. So we kind of tease out those more detailed mobility visits, for example, restaurant, gym, school, and healthcare. We treat those kind of mobility data as features that we are using in our forecasting model, and Max will talk those into more detail in a minute. Except that we also use a simulation model based on SEIR to generate the estimate effective reproduction number during the pandemic period. So the reproduction number means is kind of a factor to describe the transmission of an infectious disease. For example, if this reproduction number equals to 1, means that in average, 1 infected people will affect 1 secondary cases. So if this number is less than 1, means the daily cases will likely to be going down. And if this number is larger than 1, means we would likely to see like more daily cases in the future. So this is also kind of a feature that we use in our machine learning model to forecast the COVID cases in the future. So this is part of our teams. Again, if you are interested in our research, please feel free to check our website at system.jhu.edu. And we are growing very fast. Every year we have new members joining us. So if you also would like to join us, please feel free to check the website. And we are looking forward to collaborate with people from different fields. Thanks. And I want to pass my mic to Max.
Thanks, Hongru. Yeah, so I'm Max. Just like the other guys, I'm a PhD student in civil and systems engineering, and Dr. Gardner is my advisor as well. So I think that my role with the COVID dashboard and the data is definitely much more of a user of the data as opposed to working on the side of putting the dashboard together and working on the presentation. So I'm just going to go through an example of one of the use cases for this very rich and well put together data set that everyone has access to because of all the data is available for anyone through our GitHub page. So one of the major efforts that we've been involved in for the last for the past number of months is participating in the CDC's ensemble COVID prediction group. So it's a bunch of different modeling groups. Just like our department is very diverse and with lots of backgrounds, this modeling group brings together people with, from traditional epidemiology, cutting edge data scientists that were working on other stuff previously to try to get everyone to figure out what's going to happen, in the next 4 weeks, basically every single week. So each week we say how many new cases there are going to be and how many deaths we think there are going to be for each state in the US for every week in the next month going forward. So this is, it's occupied a lot of my time. It's occupied a lot of the time of the people in our center, and we think it's really important, obviously, because COVID is an incredibly important issue at this point, but also because it's it's something that is, as I think Frank alluded to, this is not the last time we're probably going to see something like this. It presents a lot of problems that will definitely extend to things we're going to see in the future. Having to collect new data, having to deal with the fact that your data collection methods are changing, that the situation on the ground is changing. As Hongru said, it was very useful to use mobility data in a certain way at the beginning of the pandemic to predict cases. Not as simple to apply that right now, because we now, mask wearing patterns are different, behavior is different. Now we have vaccination, thankfully. So it's definitely a complex problem. So I'm just going to go through an example here of, this is not literally what we've been working on, but this is more of an exploration of how we might, kind of a toy example of how we might go through some of this modeling. So if you look at this curve, this is just like a epidemiologic time series that we might want to predict. And so the thing that I'd like you just to take a look at here is that what we're going to be adjusting is the fit duration. So this is just a very simple linear fit to the data that we've got here. And it's fitting on this blue line, which is just 7 days. So the idea here is that you're just doing a very, very simple linear fit to the data and then attempting to predict what's going to happen 14 days out in the future. And that's the day that's indicated by the dot at the end of this red line. So this is just a demonstration of, like, let's say we wanted to use this approach to model, to try to predict what's going to happen in the future. We say, okay, let's try using a 7-day fit to see what's going to happen in 2 weeks from now. And then we test it out on this known historical data that we're looking back on. And we can see that this really doesn't work all that well. It's very sensitive to sort of these local trends moving up and down. And it does not hit the interval that we might be looking to hit. So if we scan forward, and just as a quick way of looking at the error, we can see that these are just two error metrics that we might use to assess how well this is performing, and we want these to go. We want to reduce our error as much as possible. So if we try this strategy again, except this time we try to fit the curve using a 14-day fit. So you can see that we're predicting the same distance out, but instead of trying to use the past 7 days to inform it, here we're using the past 14 days to inform what's going on. So you can see that the prediction shape is a bit different. It's not behaving in exactly the same way. And we can see that, the error did go down a little bit. Let's try doing this with 21. Sort of same process. I'm not going to force you to watch this whole thing. What I just want to draw your attention to here is that kind of intuitively, if you look at this prediction, so of a fit of 21 days versus the previous one of 14, I would say that to my eye, the curve looks a bit better. It looks like it's actually mimicking what's happening better. But if you look at the error data in the bottom, it actually is the same or worse depending on which metric you use. And that kind of speaks to something that we try to keep in mind as we do this data projecting, is that these problems are so complex and there are so many different facets to them that it's very hard to distill how well your predictions are doing down to just one metric. Perhaps it's not, if I'm someone trying to come up with a policy for my state, they probably care more about predicting an accurate trend or telling you kind of what direction you're going to be in the future than getting you to, you know, some precise error metric, which as, you know, as modeling people, sometimes I think we get a bit too hung up on that. So we really try to keep our predictions as meaningful as possible. Yeah, so one final thing, we contribute our predictions on an ongoing weekly basis. And we're developing this kind of multifaceted routine that, again, we're not doing exactly what I was just showing you. That was just kind of an example, but it is an example of the sort of process that we take where we try to come up with different ways of solving different aspects of the problem and, you know, build it into this large routine where appropriate. I'm really hoping once hopefully we're all able to move past the daily and weekly demands that are taking all of our time in the pandemic, that we can get this routine out there to help people analyze stuff in future pandemics, to, you know, to help hopefully to solve other problems as well. And also just one final thing is, this has been a tremendous learning experience for me as someone who's come into this and seen a bunch of new things. And one thing that I've really taken away is that if you're listening to expert opinions about things or people that are claiming that they know what's going to happen, the people that I have ended up trusting are people that express that there is inherent uncertainty in this work, that no one knows exactly what's going to happen. And people that claim that they do, I think generally should be trusted less than people that acknowledge that there is some fallibility in what they're talking about. There is some confidence interval in what you're predicting. And fortunately, a lot of the people that we're working with are like that and are smart and know what they're talking about, which I'm tremendously grateful for. So yeah, thanks again for listening to me. And I suppose that is it for my presentation. Thanks a lot.
Thank you, Max. At this time, we'll move over to Q&A. So please submit any questions you have. There's a Q&A button at the bottom of your screen. You can click that and enter any question that you like, and we will move through those. First question that we've got is for
Oh, sorry, Mike, I didn't hear you.
Yeah, so the question is, how do you get that data? Can you speak to what your data sources are, perhaps?
Yes, for sure. I saw that question, so let me share my screen. So can you see my screen? Yeah, this is two pictures. So back to last January, we were collecting data manually. So everything is in this Google Sheet. You can, from this Google Sheet, you can see when and who collected for which country or location and what is the data source. So everything's manually, and we have a team of volunteers. They are checking different countries in the world. Some of them, they are in charge of the maybe Europe. Some of them are in charge of the Canada and part of the US and maybe Western US or the eastern side of the US. So different people have different roles in collecting the data. But after about 2 months, since we launched this dashboard, we found it's impossible to track everything manually, especially when we decided to track over 3,000 counties in the US. And then we changed to this automation procedure. From this one, you can tell we have three main steps. The first one is data collection. We are collecting data from different authoritative data sources like local health departments or the Department of Health for each country. We congregate those information into one standard format, and then we also need to translate those data sources. They are in different languages for sure. And then we also tried to standardize all their definitions. For example, what is the case? Some place just to define if someone is tested PCR is positive, that will be a case. Some place will say PCR is not enough. We will get antigen test. So if both tests are positive, we will see that as a case. And some place will see maybe those are tested positive, but how about the symptomatic cases? And we will include those cases into our cases definition. So those are something we need to trade off and to see how we collect. This will influence how we collect the data. But once we finalize the data procedure or what data to collect, we will aggregate them into one giant form, like the Google Sheet I showed you in the beginning. And then we will publish the data into the GitHub repo. So for GitHub repo, we mainly provide two types of data. The first one is a data report, which is like a snapshot of the dashboard every day. So maybe this is a side story about the updating frequency. Like the dashboard, you see the data updating all the time, but the frequency will be about every 1 hour. You will see the data is updating in the dashboard, but in our internal GitHub, we are grabbing the data every half an hour. It's faster than dashboard, but we also provide a data report in the GitHub for the public, which published every 24 hours each. Because some location they publish data a little earlier or after. So in general, we're updating the GitHub at least once a day. And then we also have this time series table. This is kind of location and the day by day from the beginning of this dashboard. So that's how we share the data in the GitHub. And then we change the format a little bit and publish in the ArcGIS platform. And from there, we create a dashboard. And the dashboard, we have two versions. One is the desktop version I showed you in my presentation, and the other one is the mobile app version. You can switch two different versions by just clicking on the upper right corner and select the mobile version or the desktop version. So this is how we collect the data. I hope that answered your question. Thank you.
Thank you. Could you also add if you ran into any privacy issues or anything like that as you were collecting or aggregating data?
Yeah, so I always give an example of the privacy issue. I think that's maybe back to last March or April. If you remember, we have about 55 evacuees from the Diamond Princess cruise. That cruise ship was initially anchored in Japan, but the US government decided to evacuate those patients back to US continent. We may track those patients by their location. They are allocated to different hospitals or different military bases. We can track that, but I don't think it's not a good idea because sometimes people can track who that person is because maybe that's the only one hospital accepting COVID patients, and we know you are the only one people traveling from other countries. So maybe it's easier for people who want to find who the patients are, easily find the privacy information. And then we decided now to report them by each individual point. So we decided to aggregate all the evacuees into one giant red dot in our map. So it's kind of protect the patient's information, privacy information. And for some other states, I remember in Massachusetts, they have a very small, tiny island as a county, and maybe there are only 200 or 300 residents on that island, but that one is a county. In the beginning, there were only 2 or 3 cases over there, but they think it's a kind of there is a possibility for the other people to know who they are. So they aggregate that number into another county. So those 2 counties combined to report how many cases are there. So this is another way to protect the privacy. Thank you.
Great, thank you very much. This question I think applies to everybody here. You weren't planning to work on COVID dashboards or work like this when you started your studies. Could you a bit about how this has perhaps changed the trajectory of your PhDs or your studies?
I think this one changed every one of us here. For me, especially for the first semester tracking the coronavirus, I suppose everything will calm down within just a half a year and my project will stop. But like myself, I never think this one will last for this long time. And then because of I need to allocate my time to collecting the data, I have to drop one of my favorite classes. But Dr. Garner, she was so kind and she agreed that I do not need to take that rush to finish all my courses in one semester. So I have enough time for my other, for the data collection. And this one, I think is good. And on the other hand is, in the beginning, because it's only me and Dr. Garner collecting the data, and then we have a team. From that part, I know how to maybe organize a team, or maybe at least how to allocate tasks to different members. So that one is something not every PhD student could learn from their studying period. From that, I've learned a lot as well. Yeah, maybe Hongru and Max, they have their own experience on using this data.
Yeah, I mean, Max, go ahead.
I was going to say it definitely. I was not a PhD student when the pandemic started. I was finishing up a master's degree in the department and was applying for jobs. And when I think Hongru or you one of you guys definitely asked me to help you make some graphs or at something, and that was the tipping point. And then I just started to feel obliged to help with this effort instead of applying for my own jobs. And it eventually got to a point where it was clear that this was where my this was where I wanted to be in working on these important issues instead of seeking out employment. So it definitely changed my path for sure.
Yeah, for me, I think like the past year, most of the time for me, like for the second semester, are spent on the dashboard. I mean, this pandemic is not good for human being, but in some ways, it's kind of a unique opportunity for like all of us to like when the first year you're a PhD and you can just participate in such unique project and you can learn a lot that you can never learn from classes. Yeah, I think it really benefit me a lot in terms of the like research skills. Yeah, I will be very proud to be part of this team. Yeah.
Nice, thank you. So as you realize that all of these important decisions were being made around the world based on your data, how did that affect you or the team? Was that a positive indication for you? Was that negative? How did you guys take that?
So we have to be very cautious in reporting the data. We have to make sure what's going on. Like if I remember correctly, in Texas, the state level, they changed the definition of the death to someone must have a death certificate and he or she should die of the COVID, and then they will count that one as the death. But for some counties in Texas, they just see, oh, if you were diagnosed with COVID before, and if you die, and then we will see your COVID death. But that one make us a little nervous because it's the standard difference, and will make if you aggregate the county level death and the state compare with the state report, that will be slightly different, but that one is very crucial. And we got a lot of emails asking us what's going on with that. So we must be very cautious because this data we know has been used worldwide, no matter for the government or for the general public. And sometimes the communication with our users is a good experience, like especially in the early days, like in the early days when Italy or European countries, they got a surge of the virus. Many people emailed us and telling us their first-hand information. They told us, hey, we got a cases over here, but I don't see the case in your report. Can you add that one? And he sent us the resource. And we check that in source and see, oh, that's the real case. And so we report it later. And this is good communication, enable us to report the cases even faster than some major media in the US for some countries like Italy and Germany. So this is a good collaboration, but from that, we know we have so many eyes on our dashboard. So we must be very cautious on our data collection.
Max or Hongru, did you want to add to that?
Yeah, Yeah, I had a friend. I think Ensheng and I have some like bad memory about data issue back to like very early stage of the pandemic. So um, we found like some articles that kind of like blame us for not collect the data correctly or not have the regional country
It's
name
like a
correctly.
personal attack.
Yes,
Yeah.
so before that, I start to be like extremely 200% cautious about what I'm doing with that dashboard. So that is some story about the data for me.
Yeah, it besides just the realization of your extended family or friends telling you that they encountered something that you did, that's an interesting experience. But part of it is also just grappling with the fact that the information that we're working with is obviously it's tremendously there's a huge human cost just shown in the data that we're working with and that we're expressing. So that's been a huge part of it too, is trying to stay on top of the work. For me, it just sometimes, despite or kind of having to try to put aside the emotion that you might connect with, recognizing the scale of the problem and the scale of the suffering that people are going through.
Thank you. Is the team intending to continue updates to the dashboard and the data collection? And is that going to be done in the same way? And how do you account for any sort of discontinuities with that data set going forward? You have comments on that?
Yeah, that's a very good question. Actually, when I introduced our GitHub repo, I mentioned that we have a collection of all the data changes. So if you refer to if you can log into our GitHub, and you can see we have the back distribution documentations, we have the data change documentations, we have everything documented. This is a very good way for us to track everything changed officially. And every day, a lot of users email us or leave a message in the GitHub or issues channel and maybe send us a, hey, we got a drop and something like that. Can you explain why that happened? We will let them to refer to our documentations on that. But another, let me give an example like here. If you go to the GitHub, you can see the epi curve. There is a spike, maybe in the early December. That is because of the Turkey data. They released the asymptomatic cases on a single day, but they didn't provide us the back distribution cases. So that one make us a really hard time, because you see there's a spike and maybe the data reporting is wrong. We reach out to the Turkish government, but never heard from them. So we have to leave that spike on our dashboard. So that's the reason we have that spike, but everything's documented. I hope that can answer some of the questions. If you have further questions on the back distribution or the data collection, you're welcome to refer to our GitHub repo. But one thing I want to mention is we never changed the data we collected. I mean, if the official record, they change the data, we have to change it because they changed the standard. But I see we as a data mover or data transfer, we transfer the data from one location to an aggregated source. And in this period, we never changed a single data. Thank you.
What is your latest data telling you about the impact of vaccination?
If you can wait for a couple of days, you can see we will release a new type of data, which is the vaccination, like the doses has been administered worldwide. But right now, all the data is still in the testing period. But if you want to know the latest information, you can go to the Johns Hopkins Coronavirus Resource Center. They can provide you the US specific vaccination information. Thanks.
Thank you very much.
Also, just from the modeling perspective, during the time when we've started to see a significant amount of people with vaccinations in the public, in the American public at least, that the modeling I do is within the US, it has definitely altered the at least from from our perspective, the mechanics that informed the model. Whereas previously, you could more reliably use information from the past to predict what's going to happen, from further in the past to predict what's going to happen at this point. Now, we're definitely seeing very different dynamics, at least based on the past month or two.
Great, thank you. On your team, was there anybody from the biomedical engineering department participating?
I am not so sure. Maybe in the early days, we hired many volunteers. They are from different departments, like from chemistry or even Caribbean to school, and maybe someone is from biomedical school. Thank you.
Okay. What can you say about predictions of the course of the pandemic for a specific country outside the US? Can you say anything about the upcoming 2 or 3 weeks, or what do you think about that?
I think it's hard to say what like the causing factors for a pandemic. Sorry for that, my copy. I think what we know for sure is like where the case is coming from for certain country, How can we done this is by the genomic data. Genomic data is kind of like the ground truth, tell you about where are those cases coming from. For the driving factor, I mean, it's still like hard to understand why COVID is going hit harder for some country, but not very hard for others.
Okay. To what extent is your data collection automated at this point? Have you been able to establish any working agreements with your sources that you've spoken to us about?
Most of the sources, they are from the government, so I think it's open, even though we scripted data directly. So everything could be automated right now, but some data we cannot, because it depends on the format. If they are published data in a PDF or a zipped folder, and it's really hard for us to scrape using. And then sometimes if they are published in a Facebook or Twitter randomly, and not very standardized format, it's really hard for us to scrape. If that happens, we will have to collect the data manually and update it daily. So we have a very large team right now. Each of them take responsibility for certain amount of regions, and they are working on manual update. Thanks.
Thank you. What can you tell us about the variants and the rates of transmission and deadliness? Do you have anything about these new variants that we're seeing, or anything that you can report there?
Yeah, we actually collaborate with another group from Yale, and we are studied the B117 that is from South Africa and England. And we can see that based on the sequencing data, the B117 is dominate of like current confirmed cases. Most of them, like over 50 of them, are those new variant. And we are not sure about like they are different in terms of the more transmission or not, because the sequencing data is still like under sequence for most of the state. So by far, what we can say is for current RT, for the overall RT estimate, is kind of the combination of different variants. And by going forward, it will be more complex than the past years. Past year, most of them are kind of 1 or 2 variants, but start from this year, the RT estimate will be more complex.
Thank you. We had a question of if your presentation is, if you have these available anywhere. Have you posted your presentation or any of these notes somewhere?
Not yet, but if you have interest in using our information from our slides, you can reach out to any of us, so we can provide you some slide or figures if you want.
Thank you very much. How are you weighing data from any non-democratic countries or anyone where the data may be used for political purposes?
This is a kind of a sensitive question, so we got a lot of trouble on that. For example, in the early days, the map providers of our dashboard, they follow the US sanctions. which means all the mapping information cannot be used in Iran. And there is a news report on that. So should we let our data be seen by the people in Iran? From us, we think why not? Because we are collecting data independently, and this is a public health information. But from maybe government level, they have different thinking. I hope we can figure out a good solution later. Thank you.
Okay. Have you tried a multivariable predictive model? And do you have ideas on what variables appear to be the most important for your predictions?
Yeah, that's everything that we're doing is definitely multivariable. In general, as you might imagine, cases are good at predicting deaths. You have to be careful about when you want to build those relationships, because with vaccination now, the relationship between cases of deaths is very different than what it was before. And same thing with hospital capacities and new forms of treatment, that sort of thing. Mobility is generally important as well. I think maybe Hongru might have more details on that. And also, at least in the modeling that we're doing, as socioeconomic and demographic factors are really important too. Like, we know that different communities are hit in very different ways by the outbreak, and that's borne out in how predictive those different data are as well.
Thanks.
Yeah, just as Max said, that at different time point of pandemic, there's might be different leading factors. Like after the Thanksgiving, we saw some correlation between public transportation visits with the new cases curve. So I would say it's kind of the leading factor at different time point may be different. Sometimes maybe food service restaurant visits, sometimes maybe workplace visits. So it still depend on time.
Thank you. All right, one more question and then we'll wrap up. As you guys have research in a number of different areas, have you thought about using a version of the dashboard or these tools for other use cases going forward? Something that's maybe not healthcare related or something else. Have you thought about that?
Yes, of course. We are thinking about that, and also our team is working on that too. If you like to join our team and make your idea to be shown to the world, you can join us and contact with us. Thank you.
Thank you very much. Thank you for all the questions, everybody. We've got a few more, but that people have sent in. We'll look at those, but that's all we have time for answering right now. I wanted to just speak for everybody and say thank you to Ensheng, Max, and Hongru. Thanks for sharing your expertise and speaking with us today and answering so many questions. And everybody, thank you for joining our talk today and spending some time with us. We hope you enjoyed the event. Thank you very much. Take care.
Thank you.